Good day! I am Karyll Joy R. Cagampang, a Level 2 nursing student from the Visayas State University. How are you guys? I hope you are all doing fine despite our current situation. Today, we will be tackling about complications or problems encountered during pregnancy, specifically ectopic pregnancy. But before we jump into our main topic, let us first state our learning objectives. First is to define ectopic pregnancy. Second, to identify and how to assess a woman with an ectopic pregnancy. Third, to apply therapeutic management or medical management to a woman with an ectopic pregnancy. Fourth, to enumerate the causes, risk factors, predisposing factors, prognosis, and mother and fetus complications, effects, or dangers. Fifth, to discuss the pathophysiology of an ectopic pregnancy. And lastly, to make nursing care plans out of ectopic pregnancy. Now, what really is an ectopic pregnancy? Here, I have compared an ectopic pregnancy from a normal pregnancy. In a normal pregnancy, a fertilized egg normally implants in the uterus, while in an ectopic pregnancy, a fertilized egg is implanted outside the uterus. And 95% approximately of ectopic pregnancy are implanted or happens in fallopian tube, 80% in ampulla portion, 12% in isthmus, and the remaining 8% happens in interstitial and fimbriae portion. Now this creates a bigger problem when the fertilized egg is implanted outside the uterus, knowing that when the zygote will start growing. Now, there are different types and classifications of ectopic pregnancy, and these are the tubal pregnancy. A tubal pregnancy is the very most common ectopic pregnancy, and that happens in the fallopian tube. Second, the non-tubal ectopic pregnancy in areas such as cervix, ovary, and abdomen. And lastly, the heterotopic pregnancy. This type of ectopic pregnancy is a very rare case because a zygote implants inside the uterus and the other implants outside the uterus. Now, the incidence of ectopic pregnancy nationwide is according to Hospital ng Maynila Medical Center, Manila, Philippines. The incidence of ovarian ectopic pregnancy is 1 in 7,000 to 40,000 pregnant women. Worldwide, the incidence of ectopic pregnancy is 1 to 2% and 2 to 5% among patients who utilized assisted reproductive technology. The causes of ectopic pregnancy are the pelvic inflammatory disease, or known as PID. Second, inflammation and scarring of fallopian tubes from previous infection, surgery, and medical condition. And lastly, obstructions such as adhesions in the fallopian tube. Now, these three creates a blockage in the fallopian tube that the zygote cannot travel through the tube. Thus, it lodges in a strictured area and implants there instead in the uterus. The risk factors or predisposing factors of ectopic pregnancy are genetic abnormalities, hormonal factors, and history of infertility. Diagnosing ectopic pregnancy. We have two types. First is the laboratory diagnosis. In laboratory diagnosis, a urine test is taken to confirm the pregnancy of a woman. Second, a blood test, especially the levels of the pregnancy hormone, which is the HCG, or human chorionic gonadotrophin hormone. For diagnostic examinations, the physician will likely to do a pelvic exam to see or to know the size of the uterus and feel any growth or tenderness in the belly, and a transvaginal ultrasound to confirm pregnancy and to know the exact location of the pregnancy. Prognosis. An ectopic pregnancy is potentially life-threatening if left untreated. However, a proportion of cases will resolve naturally and can be managed using expectant techniques, in which a woman is monitored for signs that the pregnancy has resolved. But in most cases, ectopic pregnancies require either medical or surgical intervention. Both of these techniques are effective in removing the abnormal embryo. The complications of ectopic pregnancies to the mother is first a ruptured organ, second, severe bleeding, third, hypovolemic shock that will result to death. To the fetus, death. Assessing the signs and symptoms of an ectopic pregnancy. First, there is a sharp, stabbing pain in one of the woman's lower abdominal quadrant. This is caused from the growing zygote in the implantation site. Second, a pain when urine and feces pass. This is caused when the phrenic nerve is irritated with massive blood loss. And we will be explaining more about that when we come to the pathophysiology of the ectopic pregnancy. Third, fainting or collapse. This is a sign of an impending shock due to massive blood loss. Fourth, pain in shoulder and neck. It is also caused by the irritated phrenic nerve. Next, upset stomach and vomiting, caused by the effect of HCG. Pelvic pain, it also caused by the irritated phrenic nerve. Light vaginal spotting or bleeding caused from the ruptured ectopic pregnancy. And lastly, erectile pressure that is also caused by the irritated phrenic nerve. These are the nursing diagnoses in line with ectopic pregnancy. We have acute pain related to ectopic pregnancy as evidenced by sharp, stabbing lower abdominal pain. Second, powerlessness related to early loss of pregnancy secondary to ectopic pregnancy. Third, anxiety related to possible loss of ability to conceive, evidenced by increased tension and restlessness. And lastly, we have risk for deficient fluid volume related to bleeding from a ruptured ectopic pregnancy. The pathophysiology of an ectopic pregnancy. Legend. This particular color represents its signs and symptoms. In order for us to understand and trace ectopic pregnancy, we started on listing all of the precipitating factors, causes, and predisposing factors of an ectopic pregnancy that were discussed earlier in this video. Once the fertilization takes place, this new fertilized egg is now called a zygote. A zygote is formed. With ectopic pregnancy, there are different sites or implantation sites outside the uterus, and these are the fallopian tube, the ovary, the cervix, and the abdomen. Once the zygote is implanted in one of these implantation sites, the zygote will start growing. This growing zygote will then exert pressure on the site. We all know that these sites outside the uterus are not capable of expanding. Thus, an untreated and undiagnosed ectopic pregnancy at weeks 6 to 12, it will cause a rupture. Once the organ ruptures, there will be a massive bleeding, or a bleeding occurs. Once a bleeding occurs, the patient will manifest light vaginal spotting or bleeding, and fainting or collapsing, that is a sign of an impending shock due to massive blood loss. This bleeding also irritates the phrenic nerve. Once the phrenic nerve is irritated, the texts inside these yellow box are its signs and symptoms that were discussed earlier in this video. Now, these are the complications of an ectopic pregnancy. First, a ruptured organ of an undiagnosed and untreated ectopic pregnancy. Second, a severe bleeding from a ruptured organ. And third, a hypovolemic shock that, if treated late, it will cost the life of the patient. Therapeutic or medical management of ectopic pregnancy. For early ultrasound of an ectopic pregnancy, a sonogram is shown to the woman. A sonogram, by the way, is the image produced by the ultrasound. After the sonogram is shown to the woman, there will be an agreement that therapy could be life-saving. The woman is usually medically treated by the intramuscular, or less often, oral administration of methotrexate. A methotrexate is a drug used to stop the cells from growing, thus ending pregnancy. After all of this, a hysterosalpingogram is used to see that the pregnancy is over, and also whether the tube is still fully patent. The advantage of this is that the tube is left intact with no surgical scarring that could cause a second ectopic pregnancy. Women are treated until the HCG titer, or a negative HCG titer, is achieved. For ruptured ectopic pregnancy. When an ectopic pregnancy ruptures, it creates an emergency situation. The therapy for a ruptured ectopic pregnancy is a laparoscopy. A laparoscopy is used to ligate the bleeding vessels and to repair the damaged fallopian tube. A rough suture line on a fallopian tube may lead to another tubal pregnancy, so either the tube will be removed or suturing on the tube will be done with microsurgical technique. Hence, if a tube is removed, a woman may lose about 5% of her fertility. The nursing management of an ectopic pregnancy. Assessment. There will be no unusual symptoms at the time of implantation of an ectopic pregnancy. No menstrual flow occurs because corpus luteum continues to function as if the implantation were in the uterus. Pregnancy test for HCG is positive. The usual signs of pregnancy, such as positive pregnancy test, nausea and vomiting, will occur. Sharp stabbing pain in the lower quadrant is likely to be felt by the woman once a rupture has occurred, followed by scant vaginal bleeding. At weeks 6 to 12 of pregnancy, the zygote grows large enough that it ruptures the slender fallopian tube. Tearing and destruction of blood vessels and bleeding results. Hence, Bleeding will depend on the number and the size of the affected blood vessels. Leukocytosis, ruptured tube, and blood collecting in the peritoneum seen in vaginal sonogram. Upon arrival at the hospital, a woman who has ruptured ectopic pregnancy or internal bleeding occurs. She might present signs of hypovolemic shock such as rapid, thready pulse, rapid respirations, and decreased blood pressure. A decreased HCG levels or progesterone levels would indicate that the pregnancy has ended. If a woman waits before seeking help, abdomen becomes rigid from peritoneal irritation. Cullen's sign, a bluish discoloration of the umbilicus, and a woman may have continuing extensive or dull vaginal and abdominal pain. Movement of the cervix and pelvic examination may cause excruciating pain. Pain on shoulders, irritation of the phrenic nerve by the pooled blood in the peritoneum, tender mass and cul-de-sac of Douglas and vaginal examination. For nursing interventions, upon arrival at the emergency room, the nurse must place the woman flat in bed. The nurse must assess the vital signs to establish baseline data and determine if the patient is under shock. Maintain accurate intake and output to establish the patient's renal function. Place the patient in complete bed rest during severe episodes of pain. The nurse must perform relaxation techniques such as deep breathing exercise. Prepare the patient for an ultrasound if it is needed. Prepare the patient for surgery if needed. And administer prescribed pain medications from the physician. For the evaluation, the goal of the evaluation is to ensure that maternal blood loss is replaced and the bleeding would stop. The patient must maintain adequate fluid volume at a functional level as evidenced by a normal urine output. Vital signs, especially blood pressure and pulse rate, should be stable and within the normal range. Patient must exhibit moist mucous membranes, good skin turgor, and adequate capillary refill. And that ends our topic about ectopic pregnancy. This has been Karyll Joy R. Cagampang, a Level 2 nursing student from the Visayas State University. Have a good day ahead.